Good afternoon, everyone. My name is Aisha Usman. I work at the Mental Health Foundation Australia, and I'm your host for today's webinar. On behalf of the Mental Health Foundation Australia, I begin by acknowledging the traditional custodians of the land on which our offices stand, and we pay our respects to their elders, past, present, and emerging. We acknowledge the sorrow of the stolen generations and the impact of colonization on Aboriginal and Torres Strait Islander peoples. We also recognize the resilience, strength, and pride of the Aboriginal and Torres Strait Islander communities. On behalf of the Mental Health Foundation Australia and the CEO, Mr. Vasan Srinivasan, I would like to welcome and thank each one of you for attending today's Be Well educational webinar on trauma and post-traumatic mental health. I would like to introduce our presenter, Professor Kim Felmingham. Professor Felmingham is the Chair of Clinical Psychology at the Melbourne School of Psychological Sciences at the University of Melbourne. She is recognized for her research investigating the neurobiology of PTSD and the neurobiological mechanisms underlying exposure therapy and over 170 publications in this field. Her research has been continually funded by the Australian Research Council and National Health and Medical Research Council over the past 15 years. She has expertise in neuroimaging, psychological stress, hormonal, and memory research. She is a clinical psychologist with over 20 years experience working with traumatized clients and patients with PTSD. She is currently conducting clinical trials to identify ways to augment exposure therapy for PTSD. Please join me in welcoming Professor Kim Felmingham.
Thanks very much, Aisha. I will just share my screen and get my slides up. Oops. Hopefully everyone can see that. So thank you very much for the invitation to present today, and thank you everyone for attending. Again, I would also like to acknowledge the traditional owners of the land on which we meet. And for me, that's the Wurundjeri people of the Kulin Nations. And I also pay my respects to elders past, present and emerging, and any Aboriginal and Torres Strait Islander people attending today. So I'm delighted to present to you today, and it's following on, I know, from the talk on culture and trauma that was fantastic last week by Associate Professor Laura Jobson. And look, I think it actually is quite nice that we've got both of these talks, because her work is so important, and taking a cultural lens to trauma is just essential. I'm going to be presenting from a very different sort of lens though, and that's more looking at the biology or the biological side of trauma and looking at neuroscience. And so most of that has been conducted, unfortunately, in Western populations. So it has got a very Western lens on it. So it's really important to say that at the outset. And we really need a lot more research that's looking at cultural factors that also intersect with that. So watching Laura's talk gave me a lot of really good ideas for some research I might like to do as well. So what I'd like to cover today in the talk is looking a little bit at mechanisms involved in PTSD and current treatments. Laura did that beautifully, and some of the mechanisms that she's spoken about with cognitive appraisals and emotion regulation are very similar to some of the mechanisms I'll be looking at. However, I will be looking more biologically at some additional mechanisms as well. And then I think as a clinician, one of our key questions we always want to ask is, how can we improve our treatment outcomes in patients who have post-traumatic stress disorder? And then towards the end of the talk, I'll try and draw some implications from the research I've done and some of the science I'll be presenting on what might be some implications for practitioners for current clinical practice as well. And then I welcome any questions. I think we have a question and answer session at the end. And apologies, I have busy slides because I put lots of graphs and figures, but I will try and keep it as a digestible talk if I can. Okay, so just going to... Right, so We know, unfortunately, that trauma exposure is a ubiquitous experience and a very common one, unfortunately, for people. Many of the early studies looking at adverse childhood experiences are just highlighting the frequency of childhood trauma exposure across the world. This one is a study done in American populations, but we know that trauma exposure really is very common across cultures and globally. Increasingly with climate change disasters and forced displacement from conflict and war, we're seeing an increased escalation of trauma. And another thing that's really important to recognise is the impact of multiple and cumulative traumas as well. So just in this one study, 40% of people assessed had reported experiencing greater than 2 adverse childhood trauma experiences. And we also know in our daily lives just outside of childhood trauma that approximately 70% of us are going to experience a trauma experience that could be implicated in the development of PTSD. I think another really important thing to recognise, though, is that, there's a resilience story here. Just because people have experienced trauma, it doesn't equate to developing PTSD. In fact, the vast majority of people remain very resilient, and it's unfortunately, the more trauma experiences you have, though, the increased risk of developing a mental health issue. And it's not just PTSD that people can develop. So there may be substance use disorders, anxiety disorders, depression, PTSD, and psychosis are all things that are implicated with trauma as an etiologic factor. I will be focusing on PTSD today. That's largely because it's the most extreme exemplar of the impact of trauma, and that's where I've done most of my research as well. So what is PTSD? It really is, so it requires that you have experienced a trauma, and one of the severity where you're experiencing a threat to yourself, your own physical integrity, or you've witnessed that in others. And there's a classic constellation of symptoms. So we've got re-experiencing symptoms, that's intrusive memories, distress to reminders, and also a physical fear response typically to reminders, nightmares and flashbacks. And understandably, because these re-experiencing symptoms are so distressing, people then try and block the memories or avoid trauma reminders when they're out and about. People can have negative cognitions and mood, negative thoughts about themselves, the world, feeling constantly under threat, and often socially withdrawing. And there's a strong overlap with those symptoms and depressive symptoms too. And also there's hyperarousal symptoms, so sleep disturbances are classic, concentration difficulties, irritability, and a hypervigilance where you're scanning around for danger. So looking at this constellation of symptoms, and it's important to recognise that individuals vary with the pattern of these symptoms. So there's a lot of clinical heterogeneity in these symptoms, but typically PTSD is considered a condition of dysregulated arousal and memory. Laura Jobson in the talk last week was reporting on the memory paradox, where we have these intrusive, fragmented, very vivid memories of bits of the trauma that are associated with intense arousal, but we don't have a coherent narrative or memory of the whole trauma experience. And for other non-trauma experiences, we may have really non-specific memories or difficulty recalling memories. So I'm going to focus on 2 processes that we think are involved in PTSD, in the development of PTSD. One is our fear conditioning processes. Before we have a trauma, say we've had a car accident, we're not fearful of a green-coloured car. It's a neutral stimulus. But when we have a car accident that's been horrific and we've had an intense fear response, and the other car is a green-coloured car, that green-coloured car can become a trauma cue. So that colour of the car can then invoke a conditioned fear response. So if we then, after the trauma's over, see a car that colour, it can bring back that reflexive, it's a very automatic unconscious process where we've associated the fear response to that stimulus. And memory over consolidation, again, is another area that we'll look at. Okay. So this is one of the most comprehensive and prevailing models of post-traumatic stress disorder, where it argues that there's the trauma memory is one core mechanism that's involved in the development of PTSD, and that can involve that fear conditioning process. So the intense fear and arousal becomes associated with elements or stimuli in that environment at the time. And then if you get exposed to those trauma cues later on, it brings back in a conditioned fear process that arousal, and it triggers further intrusive memories of the trauma. And there's also, though, on the other side, these core mechanisms where we have negative appraisals, so negative thoughts or cognitions about the trauma, why it happened, about ourselves, how we're coping. And these all combine to lead to the current symptoms of PTSD. And then we may have coping strategies that aren't really that adaptive. Sometimes people use substances. They may numb out or have dissociation as a way of coping with intense arousal. And these things can just further the difficulties in adapting for us. Okay. So this is one of my busy slides, apologies, but these are some of what I think are the core sort of mechanisms that are involved in PTSD. So we've got hyperarousal or body arousal that's part of that fight or flight response. So a sympathetic arousal, our heart races, we get sweaty, we get nauseous. It can almost feel like a panic attack to a trauma cue. And we might have chronic hyperarousal, which is leading to difficulties with sleeping and concentration difficulties and irritability. We have poor fear extinction. That means we've got difficulty in unlearning that conditioned fear association. So even though the trauma's over and we're just seeing a green car, we're reacting as if we're back in the trauma. We can't learn to extinguish that fear and learn, actually, it's just a green car, and regulate the fear so it gradually comes down. There's also, as we said, those ongoing threat appraisals. And if our body arousal is really high, it's going to drive alarm signals to our mind. So our mind's going to be going, where's the danger? We also have, because of this hyperarousal at the time of the trauma, our memories get really strongly laid down because of the cortisol and the noradrenaline running through our body. And they also are what we call poorly contextualized. That means they're fragmented and frozen at the worst points in time. That's what comes back to us. We don't have the whole coherent story where we survive the trauma. We might also, especially if we've had childhood trauma, have difficulties with trust. And therefore, because of that, we have difficulties establishing caring, nurturing relationships, and we have low levels of support. And there's also difficulties perhaps in regulating intense emotions, and then we may have some dissociation, which is spacing and numbing out. So what is some empirical evidence for these types of mechanisms involved in PTSD? I've done some work where we've looked at body arousal with skin conductance. This is sympathetic arousal in PTSD, and we've found it significantly greater in patients with PTSD than different control groups. We also have seen evidence that patients with PTSD have significantly greater number of negative intrusive memories. These aren't trauma memories. We just showed people images that were either positive, neutral, or negative. And then we got people to keep a diary and write down how many intrusions they had of the negative images. And we find that they're greater patients with PTSD. And what we also found, we took measures of their stress hormones, their cortisol and noradrenaline, at the time that they were encoding or looking at those images. And we found that those stress hormones actually predicted the number of negative intrusive memories that people had. So we can see already these mechanisms are related. The greater the body arousal, actually it's leading to a stronger consolidation of those trauma memories. We've done quite a lot of work on looking at fear extinction and also the recall. How much do you retain learning to regulate that fear, that stimulus is no longer dangerous, so we don't need to have the conditioned fear response. We do this in the lab using a fear conditioning and extinction task. So what we do here is we have two neutral stimuli and we just present them 4 times each. And we record their skin conductance and they don't really change, they're the same. Then in the acquisition phase, which is where we're training fear conditioning, we associate one of those coloured circles with a mild electric shock. It's an aversive stimulus. And we see that the skin conductance increases to that aversive stimulus, or what we call the CS+. The red circle here is never associated with shock, so it becomes our safety signal, or our CS-, and that doesn't change with skin conductance. And then to measure extinction, we actually then show the same coloured circles without the shock now. And what we're interested in is how quickly does the fear come back down to that danger signal, the CS+. And what we see typically in patients with PTSD is it's slower. They still do extinguish eventually, but the fear extinction is much slower and impaired compared to controls. And there's a meta-analysis that's been done of over 44 fear conditioning and extinction studies that revealed that PTSD is associated with impaired fear extinction learning, as well as the recall. If you get people back the next day and you show them the same signals and you measure how much does their fear come back or relapse, we see a greater relapse of fear, greater increase in fear again in the PTSD patients, suggesting they can't retain the fear extinction learning. And there's also evidence that patients have difficulty discriminating threat from safety as well in these experimental studies. Now, this maps quite nicely onto neurobiological studies that we've also done. And in my lab, we did some of the early work looking at this. So this is where we're getting people into an MRI scanner and we're measuring their functional brain activity whilst they're looking at threatening images compared to neutral images, or they might be hearing trauma scripts of narratives of their trauma experience compared to a neutral experience. And we've done well over 80 of these fMRI studies now. And what we find is a really clear pattern, which is called the fear of disturbance in patients with PTSD compared to controls, where they have reduced activation in this ventromedial, so ventral, down low in the brain, medial prefrontal cortical regions. And those regions are really critical for fear extinction. So in the networks that are involved in fear extinction, patients with PTSD have reduced activation in those areas compared to controls. And we know that these ventromedial prefrontal regions actually powerfully inhibit the amygdala. And the amygdala is a really central network involved in threat and fear processing, as is the insular and dorsal anterior cingulate. So these are hyperactivated in PTSD. And it's because we have impaired inhibition onto these networks. Interestingly, the amygdala, we also know, is critical for consolidating emotional memories. So if we have greater activation in this area, we'll have stronger trauma memories laid down. And that amygdala activates all the autonomic arousal networks, which then lead to greater and chronic hyperarousal. So this model has been shown, and there's good, really robust evidence for it repeatedly in our studies. What's really interesting is when we do our exposure therapy or our gold standard treatments for PTSD, we find that this pattern normalizes. So where we have reduced activation in the ventromedial prefrontal regions, we find that that increases and normalizes after therapy, successful therapy with PTSD. Equally, we find that that hyperactive amygdala reduces after successful treatment with PTSD. So this also suggests that our exposure-based therapies really involve fear extinction, because as we're training people in exposure therapy, we're showing an increase in these fear extinction networks. So this is just some evidence showing an increase in anterior cingulate and a reduction in amygdala after we've done exposure therapy. And this finding's been replicated 4 or 5 times now. So this leads us on to, these are some of the mechanisms we think that are involved in PTSD. What about our treatment? As clinicians, that's what we're all interested in. So There's multiple expert guidelines for our best evidence-based treatments for PTSD. And so the NICE guidelines in the UK, the ISTSS globally, and also in the US, and Phoenix, Australia here. And they all converge. They've basically reviewed all the evidence with expert consensus and found that the basically elements that are evidence-based treatment are psychoeducation, doing some arousal reduction, cognitive therapy, doing trauma memory focus work, and that has the strongest effect sizes. And the most robust evidence is really around imaginal exposure, but there also is good evidence for EMDR, which is another trauma memory focused technique, and overcoming avoidance with in vivo exposure. The strongest RCT evidence base is for prolonged exposure, which involves imaginal and in vivo exposure, trauma-focused CBT, which involves imaginal, in vivo exposure, and cognitive therapy, EMDR, which is a standalone treatment, and cognitive processing therapy really focuses mainly on cognitive therapy, overcoming those corrosive beliefs. It's often used for sexual trauma, and also it has some elements of imaginal exposure too. So now my busy slide's going to get busier, apologies, but I just wanted to highlight how these treatment elements actually are targeting mechanisms involved that we think maintain PTSD. So the poor fear extinction learning is really targeted by imaginal and in vivo exposure. The over-consolidation of memories again is targeted by imaginal exposure or EMDR. The threat appraisals are targeted by cognitive therapy. Emotion regulation work, often in a staged model, especially for people with complex childhood trauma, is often done. And Marlene Kloetter has her STARE protocol, which does 8 sessions of emotion regulation training before you're moving into your imaginal exposure. And relaxation techniques can sometimes be used as well for hyperarousal. So, with the treatments, unfortunately, whilst we have about 50 to 60% of people doing well with treatment, approximately 40 to 50% of patients only display a really partial or non-response to trauma-focused therapy. So that's what keeps us up at night as clinicians. We need to work out better ways to improve and augment our treatment response. And, the hard thing about this number is, about 50% of people are responding well. So we don't want to throw this treatment out. What we want to do is work out, can we identify markers for people who might be non-responders? What are the differences between non-responders and responders? And how can we improve or augment, facilitate our treatment for those patients? Now, whenever we want to aim to improve treatment response, and we're looking at exposure therapy specifically here for PTSD, that's where the bulk of the research has been done, we need to target the underlying mechanisms of the treatment. And so, as we've already reported, there's key mechanisms are fear extinction learning. So each time that we expose ourselves to the trauma memory and nothing bad happens, it's an example, and we're in a safe context, it's an example of unlinking that trauma memory with a bad consequence, and it helps us to regulate and bring down our fear. Memory reconsolidation is also thought to be involved. So we bring the memory back to mind, but then we actually are doing that in a safe context, which means we can learn to reduce our arousal and before we reconsolidate it. And we also can work with appraisals with cognitive therapy. Now, most of the research that's been done has looked at fear extinction as our core mechanism involved in exposure therapy. And really neatly, we have really good cross-translational models. So those fear conditioning and extinction tasks I outlined before are actually really regularly used and robustly used in rodents. So we can look at animal research to try and get more precise ideas of mechanisms underlying exposure therapy and fear extinction. And also it's got good translation to human. So we see similar networks activating in humans in imaging studies as what we do in rodents doing fear conditioning and extinction tasks. So how do we improve exposure therapy for PTSD? A lot of research has happened in the last sort of 10 years looking at pharmacological adjuncts. So everyone was very excited. We actually don't have a good medication for PTSD. There's no specific pharmacological agent that specifically targets PTSD. So people have tried numerous different things, and what they've done is looked at what sort of neurobiological or molecular mechanisms enhance fear extinction, what pharmacological agents then enhance fear extinction, and then they're trialling that in humans to see does that agent improve fear extinction and does it improve exposure therapy. So people have tried D-cycloserine, which is an MDMA receptor agonist. It had been found in early work to improve fear extinction in rats. So Kerry Ressler did the first trials where he did with height phobia initially, showed people a virtual floor, and he gave them DCS or he gave them placebo at the time they were doing the exposure work. The idea is if we can facilitate the fear extinction, we're going to improve the treatment response. Now, he found it did improve. DCS improved treatment response in specific height phobia. And it's been found with many anxiety disorders actually to improve exposure therapy response. But unfortunately in PTSD, most of the trials, there's been 3 randomised controlled trials combining DCS with exposure therapy, and they've all been largely null findings. People have also looked at propranolol. If you reduce the noradrenergic response, that stress hormone response, does that have an effect? And they've found that they've looked at that mainly immediately after trauma to stop that over-consolidation of memory. Again, largely null findings, which is disappointing. People have looked at yohimbine, which increases noradrenaline. That sounds counterintuitive, but if you target it precisely to improve extinction learning, can it have an effect? But again, there's only been one trial which found null effects. And oxytocin too is thought to enhance fear extinction, and it's been trialled both as a chronic dosage after acute trauma and as an adjunct to exposure therapy, but largely null findings there, which is disappointing. So the most promising pharmacological adjuncts, one is actually cortisol. Now, counterintuitively, patients with PTSD actually have lower chronic levels of cortisol. Because they have enhanced negative feedback inhibition in their HPA axis, which we think means that over time, initially when they have the trauma, they have a massive, huge cortisol response. And then with regular repeat trauma reminders, they still have this cortisol response. And it burns out their receptors, their glucocorticoid receptor sensitivity enhances, and that means that actually overall they have lower chronic levels of cortisol. And what's been found in fear extinction tasks in both animals and humans is if you give people cortisol, it can improve fear extinction learning. So if patients with PTSD have low cortisol, they may have lower extinction as well. My PhD student Daniel Zui recently did a study where we measured cortisol during fear extinction, and he found that a higher cortisol level was actually associated with better fear extinction learning and lower PTSD symptoms. So this all was quite exciting research. Can we actually give people cortisol to enhance exposure therapy? And so a pilot trial was done in veterans in the US. They gave people hydrocortisone during their prolonged exposure session and compared it to placebo. And the initial trial found, yes, it did improve response to exposure therapy. There was greater reduction of symptoms, greater retention, there was less dropout in treatments, and they found that this correlation with as you reduce your PTSD symptoms, you're reducing your glucocorticoid receptor sensitivity. So it all sounded very exciting. Unfortunately, they've done a recent larger trial and found null effects, no significant effects, but this might speak to the fact that we need to look not just at a one-size-fits-all. They did find that the hydrocortisone had a greater treatment response in veterans who had enhanced glucocorticoid sensitivity at baseline. So what we may need to do is sort of get some tests to see who actually has the dysregulation in glucocorticoid receptor sensitivity. If they do, maybe then hydrocortisone is going to be something to improve treatment response for those people. So taking more of a personalised psychology or medicine approach to it. Okay. We've also looked at some interesting work with endocannabinoids, and this is a very recent area, but there's a few animal studies, a lot of animal studies, but only a few human studies in normal controls, finding that enhancing endocannabinoid signaling around the CNR1 receptor actually improved fear extinction. So we looked at this in 220 healthy controls and PTSD patients, and we looked at the endocannabinoid system via their genotypes on the endocannabinoid CNR1 receptor. And we actually found evidence that this receptor actually did modulate fear extinction in patients with PTSD specifically. So it suggested that lower endocannabinoid signaling reduced extinction learning. And this accords with human studies suggesting maybe if we can find an endocannabinoid agent, we can enhance fear extinction and enhance exposure therapy response. People are now starting to think about CBD oil or CBD oil combined with a small dosage of THC, but these clinical trials haven't yet been done. I should mention the most popular and area of excitement most people are looking at with pharmacological adjuncts is MDMA-assisted therapy. So 6 clinical trials that have been done, then they're open trials, have all been done by this one group, the MAPS group, and they use supported assisted therapy. So it's supportive therapy, not exposure therapy. And that's done after they give people MDMA and encourage people to just think through, allow memories to come into their mind under the influence of MDMA. And they've reported in these trials some promising findings relative to supportive therapy control groups. And they've just published last year a first phase 3 study. And again, there's some promising findings with reduced PTSD symptoms, low dropout rates especially are important. But the research is really still in early days. There seems to be much more excitement and the evidence is trailing behind because we really need replication by independent research groups. And this is happening around the world now, but the results aren't yet out. We also need to compare this against gold standard treatments, prolonged exposure and EMDR. Why would we go with MDMA-assisted therapy if we've got these other therapies that are already there? So again, it's speaking to, we need to work out maybe this therapy, which may be a little bit less accessible for people. We don't know that yet, but maybe there's certain groups, and certainly the MAPS people took people who were quite treatment resistant. So they hadn't responded to other therapies, and they were the people they were trying to recruit into this trial. But we also need to examine the mechanisms more here. This is very early days for this research. So is it about fear extinction? Is it about memory reconsolidation? These are some of the questions that people have raised and we're still exploring answers to. Okay. I'm also been doing some work in BDNF, which is called brain-derived neurotrophic factor. Now, what this is, it's a neurotrophin, it's a trophic growth factor, and it actually enhances synaptic plasticity. So it's really critical for learning and memory processes. And animal and some human control studies have found that increasing BDNF can enhance fear extinction. And there's also some studies showing that actually if you also have the BDNF Val66 MET genotype is the best way to look at this in humans. The low expression MET allele was associated with impaired fear extinction learning and increased amygdala and reduced ventromedial prefrontal activity during fear extinction, which mimics that fear circuitry pattern we see in PTSD. So we have done some studies looking at, looking at this MET allele with the BDNF Val66 MET genotype. We've found that impaired fear extinction learning, which is shown by greater skin conductance response to the CS plus compared to the Val MET. And so the MET allele is the one with the low expression BDNF. That actually is associated with poor extinction learning and impaired extinction recall. So we're sort of replicating what others have found, but we found this in a PTSD group as well. So I did a study where we found that, again, this polymorphism moderated the relationship between PTSD symptoms and fear extinction learning. So people with the low expression MET allele actually had poorer fear extinction and higher PTSD symptoms. And we've also translated this into the clinic. We have patients going through doing exposure therapy. And we found that the PTSD patients with the MET allele showed a poorer response to exposure therapy. So those with the low expression BDNF. So this led to my current clinical trial, and this is looking at a non-pharmacological adjunct to exposure therapy. Because we really, from this work, we said, if we can increase BDNF in the brain, can we facilitate fear extinction learning? And if we can improve that, can we facilitate exposure therapy response? And interestingly, the best way to increase BDNF in the brain in rodent and human studies is via moderate intensity exercise. It also, interestingly, increases cortisol and endocannabinoids. So this is just some pilot work we've done showing that 20 minutes of moderately high intensity aerobic exercise, we've actually got a range between 50 to 70 VO2 max, because some people with PTSD aren't very fit, so we need to have a bit of a moderated range for people. But exercising at that level for 20 minutes leads to significant increases in BDNF levels. So what we're doing now is a current clinical trial that we are recruiting for. I'm just plugging a trial. It is free therapy for patients with PTSD, and we're doing evidence-based, we're doing prolonged exposure therapy, but we're doing it with and without exercise to see if doing exercise prior to each session can actually enhance the BDNF level and enhance then people's response to exposure therapy. And so that randomised controlled trial is currently underway, and we're running it through the Phoenix Clinic, Traumatic Stress Clinic. So if anyone is interested or has patients they'd like to refer, please feel free to follow those links. Another really interesting non-pharmacological adjunct for me is sleep. Because sleep disturbances we know are really severe in PTSD patients. Many patients actually only have 3 to 4 hours sleep a night, and for years, days and days and days, week on week, year on year. There's delayed sleep onset, nightmares, waking and sleep fragmentation. And what's really fascinating about sleep is there's good evidence it influences these key mechanisms involved in PTSD. So emotional memory consolidation, as well as fear extinction learning and recall. So there's evidence now that reduced sleep or impaired sleep, some people say particularly REM sleep, but others don't find that, but reduced sleep in quality in general is associated with increased negative memory consolidation and impaired extinction learning, which is, again, that pattern we see in PTSD patients. But bizarrely, almost no one has studied sleep, fear extinction, memory in PTSD populations. That's what some of the work is we're doing. We've recently done a meta-analysis where we found that slow wave sleep was linked with safety signal learning. And also, interestingly, we found REM sleep was associated with poorer fear extinction recall, but only in males. So we've also looked at fear reinstatement. So that's how do people relapse after they've been re-exposed to trauma. So this is a standard fear conditioning extinction task. And then we give people 2 bursts unexpectedly of the mild electric shock, and we measure how their fear rebounds again. And what we found was patients with PTSD who had sleep disturbance, so less than 8 hours sleep a night, and longer sleep onset, took longer to get to sleep. They actually had a greater fear relapse after being re-exposed to mild electric shocks. So it's suggesting that sleep disturbance is actually not only can impact on how strongly you consolidate memories and how much you can reduce and regulate fear, but it also can lead to a fear relapse. And that's concerning because some of our treatments with exposure therapy, some of the residual symptoms are often sleep. And so it might actually lead to people being at risk of relapsing after treatment. So I think it's really important we acknowledge clinical heterogeneity again. A lot of this work has just been done treating PTSD as a one-size-fits-all symptom. But we know, and a lot of our research is centred on fear-based and threat-based learning, but fear extinction models can't explain all PTSD symptoms. There's intrusive memories, there's dissociation, there's predominant avoidance or depressive symptoms. What about the impact of childhood cumulative trauma versus single adult trauma? And I'm particularly interested in critical sensitive periods in early childhood, early adolescence. What happens when trauma happens there? And do they have particular impacts on the neurobiology of our development? So just finishing up, what are some possible implications for our current practice? I think first up, it's important that, we try to provide trauma-focused treatments for clients with PTSD. There's a really limited accessibility out there for patients, which is really problematic. But from our research and from this science, first up, it's really important to recognise it's not a one-size-fits-all model. There's multiple mechanisms involved in PTSD, and we've got different evidence-based treatments. And as Laura Jobson talked about, it's really critical to consider cultural factors in all of our formulations. But, so really a case formulation and an individualised approach is really important, not just diagnosis, and we apply a diagnosis and do a one-size-fits-all treatment. So using our case formulation, it's vital we can identify for each individual what are the key mechanisms for that person that are driving the PTSD. And then we can target our therapy. So is it over-consolidated trauma memories? We may go more on the trauma memory type of work. Is it appraisals? We may use more of a cognitive-based approach. Is it avoidance? We may use in vivo exposure and really emphasise that in our treatments. Or it may be that we've got all of it and we need a really combined integrative approach. And client choice is always critical. We can never force a client to try trauma-focused work. We can just encourage and provide psychoeducation and normalise symptoms and talk about available treatments and providing referral options. From this research, though, it's suggesting that focusing on improving sleep and exercise may have a beneficial effect beyond well-being, but actually mechanistically are trying to assist with the maintaining factors that are actually involved in the mechanisms of PTSD. If you're not trained in delivering trauma-focused interventions, you can still assist someone with PTSD by focusing on improving sleep and exercise, by providing psychoeducation and normalising symptoms. We might explain how avoidance can keep a lot of these processes going and, encourage someone to gently try and reduce their avoidance. We might help them cope with intrusive memories. Often what we use is a then versus now method. So training people, because often when we get the intrusive memory and that cued condition response, it takes us back to the time of the trauma. So if you can ground someone in the now and get them to list what's different now, it can help them actually cope and bring them back to the now more quickly and take them back out of that trauma environment. And obviously providing referral options for our clients. So you can refer to specific PTSD trauma-focused therapies, and the Phoenix Traumatic Stress Clinic does offer free therapy for people if they meet criteria for PTSD. There are research trials, so people come in and have to be randomised to different interventions, but my current BDNF trial is running there. But also if you want to receive training for trauma-focused therapy, again, there's really good training options that are out there. So I will finish up now. Sorry, I've gone a little bit over time, but hopefully that's covered some of the science behind it and how we can try and improve treatment.